Good morning. It's a pleasure to introduce Marino Fröhlich. She's a second-year resident at our department and is finishing off her common trunk before she will return to the field of her interest, which is urology. But before that, she will give our morning round on a topic you chose, on differentiated thyroid cancer. Enjoy.
Good morning, everybody. As Dr. Vettel already told, we will have a short overview today of differentiated thyroid cancer. And the incidence of thyroid cancer appears mostly between 25 and 65 years and is higher in female than in male population. It's 3 times higher in female population. Risk factors as genetic factors, as a MAN2 syndrome or radiation exposure seems to be risky for appearance of thyroid cancer. Thyroid cancer can be classified in different carcinomas. The differentiated carcinomas include papillary carcinoma and follicular carcinoma. Then we have undifferentiated carcinomas, anaplastic, and we have also medullary carcinomas. As you can see, papillary carcinoma are most frequent thyroid cancers and have a really good 5-year survival. Anaplastic carcinoma are really rare, and they have a bad outcome after 5 years because of their really aggressive behavior. After this short overview, I will want to imagine that you have a patient in your outpatient clinic with a suspected thyroid nodule and maybe detected on a physical examination or with incidentally noted on other imaging status. What would you do the next? First of all, we will perform the anamnesis. There it's important to ask the patient about the radiation exposure, the positive family history. Maybe there are signs for hyperthyroidism or clinical signs as dysphagia or disorder of breathing or stridor, or maybe hoarseness. Next, we will go on with laboratory examination. For this, we will check the thyroid hormones level and vitamin D and calcium to exclude the hyperparathyroidism. The calcitonin will be detected if we are deciding to go for surgery in nodule, and antibodies should be checked if we have a patient with a hyperthyroidism. Scintigraphy. What kind of role does it play in the workup level for thyroid nodules? According to the guidelines, scintigraphy should be just performed in patients with a subnormal TSH to detect if the nodule is non-functional or functional. And you should know that most endemic nodules are non-functional, but just a small part of these non-functional nodules is malignant. So scintigraphy shows us just if the nodule is function, not function. It does not give us the proof of malignancy. Therefore, we need other tools for detection. And this could be, for example, sonography. Ultrasound should be performed in all patients with a suspected thyroid nodule, and it answers a question about anatomy of thyroid gland and has also established some signs for malignancy. For example, hyperalkanicity, blurred and restricted margins, internodular vascularization, or microcalcification. It also shows us the status of cervical lymph nodes, which can be divided in subregions and summarized into central and lateral lymph nodes. So now we have our findings in sonography. The sonography findings can give us the information of the level of malignancy suspicion. And what do we do the next? What do we do with a high suspicion finding in the sonography?
Fine needle aspiration?
Yes, that's true. That would be the next step in the diagnostic. According to American Thyroid Association, we should perform fine needle aspiration in high suspicious or intermediate suspicious findings in ultrasound, which are bigger than 1 centimeter. We should perform also fine needle aspiration in tumors bigger than 1.5 centimeters if they have low suspicions on ultrasound, and if they have low suspicions on ultrasound but are bigger than 2 centimeters. There is no recommendation for benign findings as cystic formations for a fine needle aspiration. So from this fine needle aspiration we can get a cytopathology, which can be subdivided into 5 groups, type 1 to type 5, according to British Thyroid Association. And this helps us to decide how we are going on with our management of this disease. If you have a finding of cytopathology with the type 1, it's a non-diagnostic finding, and you should first of all repeat the fine needle aspiration. And as we could see in studies that of this finding, there were 7% of patients have proved the malignancy, you should go for it with a close follow-up by ultrasound or discuss an operation if there are changes in the follow-up. If we have the finding of type 2, it's a non-neoplastic finding of cytopathology, you should do just a follow-up. If we have type 3 in cytopathology, we can see their follicular lesions, but it's not clear what to do about this. I will tell you something more about this a bit later. And type 4 and 5, we got a diagnosis of malignant changes in the cytopathology, and that's why we should go for operation. If we are going for surgery as a therapy, it is important that we have to ensure that this surgery will be performed by our experienced surgeons to minimize the postoperative complications. And also, if we go for surgery, we should ask us some questions. Should we do a hemi or a total thyroidectomy? Should we do a lymphadenectomy, or do we need radioiodine therapy? So, if we have the type 3 diagnosis in cytopathology, it's not specific for an FNA to diagnose a follicular carcinoma, because the diagnosis of follicular carcinoma requires a vascular or capsular invasion, and this we can just get from histopathology. So that's why here is surgery, diagnostic and therapeutic point. But we can also decide, should we go for the first step with the total thyroidectomy, or maybe first of all a hemithyroidectomy where we have the nodal, and then to complete the surgery. This should be discussed on an interdisciplinary tumor board or with the patient. If we have follicular thyroid carcinoma, we have to go on with total thyroidectomy, as I showed you before, because of vascular invasion, and in patients over 45 years. We should do not perform a prophylactic lymphadenectomy if we do not have any suspicions for lymph node metastasis, but we have to do one if we have oncocytic variant in the histology. Radioiodine therapy is not indicated in follicular carcinoma if we do not have vascular invasion. So summarized, you see here, we perform maybe a hemithyroidectomy and detect vascular invasion, then we have to complete the surgery. And if we have in the histopathology also oncocytic tumor cells, we should do a lymphadenectomy. If we have a papillary carcinoma in our cytopathology, which is smaller than 1 centimeter, we should perform a hemithyroidectomy, and we do not need to complete this after surgery. There is no evidence for lymphadenectomy if you don't have suspicions on sonography for the lymph node metastasis, and there is no radioiodine thyroid necessary. Exception is a multifollicular papillary carcinoma with more than 5 foci. If we have papillary thyroid carcinoma bigger than 1 centimeter, we should go on with a total thyroidectomy if the tumor is bigger than 4 centimeters, if there is extrathyroidal extension, if we have positive lymph nodes, and if we have just a smaller nodal, 1 to 4 centimeters, and we do not have extrathyroidal extension and no suspicions for lymph nodes, we can also discuss a hemithyroidectomy. But also in this case, there are some reasons why we should perform a total thyroidectomy. And these are signs as prediction factors, risky factors as age over 45 years, central nodules, and status after radioiodine therapy or positive family history. So now to the lymph node dissection. If we perform on papillary thyroid carcinoma, is not indicated prophylactically, but it should be discussed or it should be performed if we have risk adapted. So in bigger carcinomas with invasion, T3, 4 carcinomas should receive a prophylactic lymph node dissection. In patients who are older than 55 years or younger than 15 in male patients, and if there are bilateral multifocal tumors. In papillary thyroid carcinoma with suspected CN plus lymph node status, we should perform a central lymphadenectomy. In Europe, you should also perform a ipsilateral lateral lymphadenectomy and contralateral lymphadenectomy if there are more than 5 positive lymph nodes. In America, you do the lateral lymphadenectomy only if you have the histological confirmation of these positive lymph nodes. So after the surgery, you can complete the TNM classification of your tumor findings for the staging, which can help us to stratificate the risk and lead us through further management of the disease. But there is a part of this TNM classification, another classification according to American Thyroid Association, which divides the patients in 3 groups with a low, intermediate, and high risk nodules, and there are summarizing some TNM classification values, factors, and they help us also to go on with the further managing of the disease. So low risk, you see, have no metastases, has all resected tumor, no rest of the tumor, no invasion, no aggressive histology. And intermediate risk, you have microscopic invasion, but no macroscopic invasion. You have just cervical lymph node metastases, no further lymph metastases, no distant metastases. And in high-risk patients, you have macroscopic tumor invasions, you have incomplete tumor resection, and distant metastasis. So depending on the risk stratification, we can decide, should we do now the radioiodine therapy after surgery or not? And it is considered that we should do radioiodine therapy in patients who had received a total thyroidectomy and are intermediate risk level, or according to TNM classification, all patients with PT1B or 2 with vascular invasion or histologically confirmed positive lymph nodes. And is routinely recommended after total thyroidectomy in high-risk patients. So according to TNM classification, all patients with T3 or higher stage. Now to the take-home messages. TSH and sonography should be performed in every patient for the workup for suspected thyroid nodules. Scintigraphy is reserved just for patients with hyperthyroidism. FNA procedures should be performed just in nodules bigger than 1 centimeter and depending on findings of sonography. And surgery for cancer, you should perform a hemithyroidectomy if there is a microcarcinoma and tumors with low risk features, smaller than 2 centimeters. Otherwise, you do a total thyroidectomy. And prophylactic lymphadenectomy is reserved for patients with PT3 and 4 cancer. I'll thank you for your attention.
Thank you very much for this nice overview. It's always nice to look again, even if we learned that many times at all these detailed prognoses. Maybe I have a question. What's the regulation in Switzerland with the board of surgery? Do the people, how many thyroidectomy they need to do in Switzerland to have that? Do you know also for us or for the ENT as a patient or referring doctors? I'm not sure where I should send the patient.
So as for now in Switzerland, there's no regulation, but there will be one coming, but we don't know the numbers that will be related, and we don't know if the numbers will be related to the clinic or to the person. So far there's none. There's a lot going on towards putting patients into Eurocrine, which is a database to have a control for the quality, to see basically also the follow-up on how many patients have complications, and then basically this should be a basis to then go back and see if there's an issue. We know that there's studies that show that sort of what is considered too little is lower than 50 per year, basically, of these. But there's been a work that came out last year that below 25, basically, there's a clear increase in risk of complications. But that's, of course, not for lymphadenectomies, that's just for thyroid cancer, sorry.
What's the training? How are people trained? What's the minimal number of thyroid surgery that need to be done to get the board of surgery in Switzerland?
For the board of, because it's general surgery, I think it's 5. Actually, for the general surgery,
5.
Only 5, yes.
And ENT, do you know if they have the same?
I don't know.
And the UMS, there is a UMS for endocrine surgery, right? The European board. What's the regulation here? Do you know?
The minimum amount, I'm not sure, because there's an exam and then there's you need to do surgery. So then the experts come and see you do surgery. But I'm not aware that there's a minimal number of surgeries that you have to have performed prior to the exam.
So clearly there is an issue with 5 thyroidectomy, and then you're basically free to perform this procedure. There is here, that's a regulation in Switzerland. This needs some revision here.
That's true, yeah, that's true.
My next question is about minimally invasive surgery
Yes.
for thyroid. I mean, either laparoscopy or robotic. I think there is big interest into that. Although it's a small incision, there's some advantages. I think. Would you just comment on this minimally invasive surgery for thyroid cancer?
Absolutely, that's a very interesting approach. So there's been the transaxillary minimal invasive, which is in Asia. That's where it's done the most. I mean, there's quite a large access path. And now there's the newer one is the transoral, which is, I find very interesting because you can go transorally and then you only have a scar on the inside of your lip, which seems to be promising. It started in Italy and in Germany. And the numbers are increasing, and I think that's a path to go for, at least in the beginning, for smaller nodules, maybe not for cancer in the beginning until there's enough expertise on that. But apparently the vision and everything is quite good, so I think that's something to be invested. Yeah. Maybe I just want to say that there's quite a lot have been changing. So if you look at the old German guidelines, they're not accurate anymore, and it's all the trend goes towards doing less, because we think that there's quite a big over-treatment of this kind of cancer. And very important is the risk stratification, because there are some patients that really need aggressive treatment and need radioiodine therapy, and these patients need to be completed and need to have also maybe a lymphadenectomy. But most of the patients are really very low risk and will be overtreated with a total thyroidectomy and a lymphadenectomy, and that's the trend, to do less.
Yeah, I would have a question. I can understand the overtreatment, because if you look at your Thai classification, in 97% of the cases you can just do surgery based on what she was showing. So only in the Thai 1 or 2 you don't do anything. That's only in 3% of the cases.
That's true, but then there's only a small percentage of people that will have that. Most of the people have Thai 2. And the people that get punction should already have some sort of sonographic high risk or sonographic risk features. So if you or need to have a bigger nodule. So it's not the most people won't get an FNA at all, and those that get one, most of them have a Thai 2. So especially in Switzerland, we have very good cytopathologists.
Thank you. Thank you.